Okay, we're going to go ahead and press on. We're going to do these review questions. We have 5 different sections to review, which means about 100 questions. And because of that, realizing that you all you want to learn, but you also want to go get some food and probably a couple of drinks after today, we're going to try to keep it moving pretty quickly. Sound right, Rick?
I was going to drag it on and drag it on and drag it on.
That's right, that's right. The heckling
Get that
starts.
one out of here.
That's right.
She is a troublemaker.
We know who that is.
Yeah, we
remain
do.
unnamed.
We know. We get your address, Angela.
Okay, so let's start off. First question, which is a sign of depression? Pressured speech, polydipsia, hearing voices, thought broadcasting, or loss of interest in previous activities? What do you all think about that one? E, loss of interest in previous activities. That sounds pretty good to me. I think, we don't need to say much more about that. You all got that one.
Well, what's the answer to A? What's pressured speech the answer to?
Do it.
Can I just do that one?
Sure, right.
Did I know that one? It's mania, right? Thank you very much.
Bipolar
Thank you,
disorder.
right. I don't know what you said in the lecture. I won't do any more interruptions.
That's okay.
All right, the 45-year-old female presents to the emergency department reporting numbness of the left arm and leg. No medical explanation can be found because the doctor doesn't know what he's doing, which best describes her disorder. Now, in the somatization, conversion, psychogenic pain, hypochondriasis, bipolar affective disorder. I have no idea what these words mean. So you want to pick one quickly? We're going to pick a conversion disorder. Somatization and hypochondriasis are kind of close, to tell you the truth, but conversion disorder, I'm pushing a button here. Suicide now.
Right, and so there was conversion disorder. Remember, it's an acute onset, dramatic neurologic deficit. Okay. Number 3, suicide.
Where did it come from? Freud.
Is that right?
It's a conversion from anxiety to somatic things, so that's where the word came from, Sigmund Freud. Thank you very much. Conversion.
Very interesting. Okay. Which of the following is true with regard to suicide? Males attempt more often. Females succeed more often. Widowed men are at greatest risk. Depression and drug dependence are not major risk factors, or most suicides occur in the winter. What do we think about these? C, widowed men at greater risk. Exactly. Remember that women attempt more often, men succeed more often. Drug and dependence and depression clearly are risk factors, and most of these suicides occur in the spring. So
I would
C is
think
the right answer.
widowed men would be kind of happy, kind of go-lucky guys. You know what this?
I guess it depends on what.
That's enough out of you.
We'll
What the following is true of Munchausen syndrome. Baron von Munchausen. The individual's acts are involuntary, key word there. Hospitalization is the patient's primary objective. They usually are not healthcare workers. It's bad terminology there. They try to avoid invasive tests or procedures. They seek narcotic pain medication. So these people, what do they want to do? They want to come into hospital. They want to have give me all the procedures. And remember the proxy one where they make their kid sick or they sound like the kid is being sick?
Number 5, 15-year-old female presents following syncope. On exam, she's well developed, has dry mucous membranes, and has some dental enamel loss. Pregnancy test is negative, sodium's a little low, 130, bicarb, look at that, CO2 is low at 15, glucose of 52. What's the most likely diagnosis? So, boy, what do we think is going on here? Is it psychogenic polydipsia, DKA, bulimia, methanol intoxication, or anorexia? Which one do we want? Real loud. C, that's like you got like you mean it. Right, C, bulimia, exactly.
What's
So
her
this is-
occupation? She's a jockey. Do you know that?
What?
Jockeys vomit all the time to maintain their weight. At the racetracks, they have a special
didn't know
stall
that.
for vomiting. Did you know that?
I did not know that.
Come on.
It's amazing the things that
These
you
are
learn.
jockeys.
Freud, jockeys, this is incredible, Rick. Okay, next.
These are all an exam. Extra credit. Which of the following would be consistent with that? Organic as opposed to functional cause of acute psychosis. Organic. Age less than 40. It's usually over 40. Auditory, visual, gradual onset, sudden onset, normal mental status. So pick one of these. Visual, isn't it? Visual? Remember this, pink elephants. When you see pink elephants, think alcohol. Alcohol is an organic brain syndrome. Pink elephants, visual. I'm just trying to help it, Peter.
That's good. I like it. Pink elephants. I'll never forget it now, Rick.
Word associations.
Excellent. Okay. Next is
I'm pushing a
number
button.
7. There we go. Patients found to be comatose, blood pressure 260/160, pinpoint pupils. What describes their intracranial hemorrhage? Is it thalamic, pontine, cerebellar, an intracerebral occipital hematoma, or an intraventricular hemorrhage? Which gives you coma and pinpoint pupils? Pontine, good. Just pattern recognition and knowing that one. That's right.
Patient presents with paralysis involving his face and arm greater than his leg on the right side with sensory findings in the same distribution. Exam reveals visual cuts of the right temporal, and left nasal, and this would be most consistent with, and I know for a fact, frankly, that when I took the exam, I'm not supposed to say this, questions like this were exactly in there. Totally irrelevant, but this was, they wanted to know what are the findings associated with blocked up arteries. So which one is this? Left middle cerebral. And if you know, 95% of them are left middle cerebrals, but for exam purposes, you know, they can put anyone they want. So I would take a little time to study that. I know it's not relevant.
Yeah, and again, it's involvement on the right side, right, of the body. So you know the answer's got to be one on the left, so it makes it down to A, B, or D. It's, you know, arm, leg sort of stuff. That's not basilar, right? So it's one of these anterior circulation ones. It's either the anterior one or the middle one. And remember, the anterior one is where you get leg, and the middle one is where you get more face and arm. So there you go.
And remember, you look to your lesion. I know, you don't want to talk about that.
The most critical fact.
The eyes look to the side of the lesion, so your eyes look to the left in this case.
Okay.
I know you didn't want to talk about
Number
that.
9, patient presents with acute left-sided hemiparesis involving the lower limb greater than the upper limb. So it's left-sided and it's mostly leg. Sensory deficits, same distribution. So you're weak and you're numb on one side, but it's mostly the leg. Also difficulty walking. Maybe it's related to the leg. Most likely diagnosis, is it a right ACA, right MCA, right PCA, left basilar, or left ACA? So let's figure this out. The symptoms are on the left side, so which one are we thinking? Left or right that's involved? So the right's involved, okay. Is it ACA, MCA, or posterior? Real loud? Anterior, right, ACA, that's exactly right. Remember, leg more than face and arm, you got it.
Quadriquinary syndrome is characterized by which of the following is synonymous with Cutis medullaris syndrome? Upper motor neuron findings with the hyperreflexia, compression of peripheral nerves S2 through 5, saddle anesthesia is present but rectal tone is preserved. No, sensory deficits only. So, conus medullaris is where the spinal cord ends, around 1 or 2. It's a little bulging of the cord kind of thing. Compression there is like a compression of the cord, and it has some symptoms like the chorda, but not all of them. This is lower motor, so everything's flaccid. This is not upper. Compression of the answer's got to be C, and saddle anesthesia is present, but rectal tone is preserved. No, you would have a loss of rectal tone in association with this, and this is motor and sensory. So it's pain, lower emergency here. So we got C for the answer there.
Very good. Okay, number 11. 4-year-old is evaluated following a, quote, shaking episode, which of course usually makes us think it's a seizure. Episode lasted several minutes, and now the child appears normal. Has some mild URI symptoms, but on exam, febrile of 39.5, no meningismus, and is playful. What's the most appropriate next step? So first of all, what did this person have? Yeah, simple febrile seizure. Kid looks great now. So what do we want to do? We want to do an LP, give some Tylenol and observe, give Cipro to the staff and everybody in the waiting room, CBC blood culture cath UA, or ceftriaxone. What do we do for simple febrile seizures?
All of the above?
all of the above, if you want to be really aggressive. What do you think? B. Right. So give them some acetaminophen and observe them. These patients, within the take-home message here is simple febrile seizures do not need LPs. Again, as long as they're looking good, not having petechiae, meningismus, you know, the only time you might tap somebody looking good with a simple febrile seizure is if they're on antibiotics. They're already on antibiotics, and you're worried it's actually a partially treated meningitis. You might go ahead and tap that person. But otherwise, they're
and
good.
Tell them to stop marrying family members to each other in Kentucky. A 40-year-old presents with severe headache, nausea, and vomiting. That's intermarriage causes this. Didn't you know that?
Simple febrile seizures?
Yeah, absolutely.
I'm learning a lot of things
runs
today
in families.
I was not aware of.
Jesus, you need to go to my lectures. All right, a 40-year-old presents with severe headache, nausea, and vomiting for 24 hours. Reports he has never felt anything like it before. His CT is negative. Which of the following is true? Subarachnoid hemorrhage has been ruled out with a negative CT at 24 hours. Wow. A negative LP would rule out subarachnoid. That's got to be the answer for the book. Xanthochromia will always be present. We never say always. MRI is the next most appropriate study test. Well, no, probably not. Patient should be discharged for an outpatient eval. So for the purpose of the test, the answer would be strongly B. Any Canadians here? Because they don't do this routinely. They really don't. Did you know that, Peter? Canadians don't routinely do tests?
I understand that. But if you're taking the ABEM exam,
That's
you
right.
might want to do it.
Canada is part of America.
Just saying.
It's
That's
America.
right. I know, I'm
It's
just saying.
America.
Okay. All right. It is. That's a good point. Where are we? Oh, myasthenia.
Myasthenia
Thanks very much.
gravis.
Okay, which of the following is true for myasthenia gravis? Myasthenic crisis can lead to respiratory arrest if untreated. That sounds semi-reasonable. Let's look at the rest. Distal limb weakness is greater than proximal limb weakness. That kind of goes more with neuropathies, right? Most have an associated thymoma. This is kind of a picky thing. You can certainly have an associated thymoma, but do most have it?
No.
Most don't. The Tensilon test is associated with SVT and ventricular dysrhythmias. Does that sound right? We knew it did something bad. They had to be under the monitor, but what does it give you? Asystole, right. So it's not SVT and ventricular dysrhythmias. More common in men than in women? Probably not. So what do we think here? Our answer? A. Yep, and that's right.
A 32 overweight female presents with chronic severe headache. CT is negative, LP is negative, except for markedly increased opening pressure. Which of the following complications are of her condition? So this is a two-part question. You need to know what the diagnosis is, and now what is the complication of that diagnosis. Really, this is a cheating type question, which is perfectly appropriate for the boards. So monoarticular blindness, cerebellar ataxia, homonymous hemianopsia, if you can't, severe headaches after LP, sixth nerve palsy. It's a kind of technical question here. You like E? The answer is always E. The answer, whatever the question is about what nerve, it has got the longest track through the head. It is most likely to get pulled. It's the one that's screwed up in cavernous sinus thrombosis. Pick the sixth nerve.
When in doubt. Good.
Would you agree with that?
I would agree with you.
Thank you very much.
That's true. I don't have any historical or philosophical points to make about that, but we'll move on. Number 15, which of the following is the most effective for treatment of an acute migraine? Okay, we do this all the time. Amitriptyline, prochlorperazine, metoprolol, verapamil, ketorolac. What do we think? Acute migraine, how are you going to treat it? Which one do you want? B, right. So this is basically compazine, prochlorperazine. So just going back real quickly, A, C, and D can all be used to prevent it, right? But the only two treatments there were either the ketorolac or the prochlorperazine, and that's much better than prochlorperazine. Yeah.
So a recommended treatment for bacterial meningitis in a 10-day-old should cover the following. This is one of the things that you need to know, because this is a kind of a constant. So you're going to pick, I think we went through this in the lecture not too long ago. I think we're talking about D. So Listeria is 10%, Group B is 50%, E. coli is about 30%. Listeria is the ampicillin one.
Okay. Which of the following is consistent with a syringomyelia? All right, you just tell me yes or no on these things. Usually involves the lumbar spinal cord. No, it's usually up in the neck, right? Loss of pain and temperature sensation usually occurs in the feet. Now we just said it was in the neck. Is associated with migraines. Never heard that one. Is defined as an expanding central cavity in the spinal cord. That sounds pretty promising. CT scan is the most appropriate diagnostic study. Nah, MRI is going to be much better than CT for looking at the cord. So we're going with D. Very good.
A patient with a peripheral facial nerve palsy generally has anhidrosis. Remember, that's a sympathetic chain kind of thing, Horner syndrome. Can't move the frontalis muscle. Has decreased sensation. No, sensation is cranial nerve 5. It's masseter muscle. Has decreased masseter. That's 5 too. Has ptosis. We like that one by default. So you'd have to say the answer here was E. Agree?
Oops,
What the heck am I doing?
no. Cranial nerve 7.
7, I'm sorry.
7. You were going with 3
I
with
get
the, with the
distracted. I
toes.
get
Exactly,
distracted.
you got
I'm
distracted,
sorry.
right.
So, doctor, I'm having a stroke. They're not having a stroke. If they get her out of here.
Again. Right.
So
this-
yeah, you can't move your forehead. I'm sorry. I just kind of got out of control
Is that
there.
a TIA? That's okay.
Get out of here, Angela.
Okay. Peripheral cranial
sorry.
nerve 7 palsy is associated with what? Lyme, stroke, herpetic Whitlow. What's that one? That's the stuff on your finger.
Finger.
Erysipelas. That's not it. Viral perititis. Ooh, it kind of sounds like it's the right region, but what do we think? Lyme. Good. You knew that one. That's it. Good.
45-year-old presents with from home complaining of double vision, trouble swallowing, and speaking after eating a 12-year-old can of baked beans, which is true regarding this diagnosis. Again, a compound question. You need to know the diagnosis. Obviously, we're talking about botulism. Results in ascending paralysis. No, what is ascending paralysis? What's the most common one we can think of? Guillain-Barré, yes, ascending. 72-hour
Check.
onset. No, I think it's more quicker than that. Diplopia is the latest symptom. I don't even know what that word means in there, but that
It's the latest symptom.
The
It's the
latest
whole
symptom.
fad right now.
produces cholinergic effects. Cholinergic. The way I can remember anticholinergic and for cholinergic, anticholinergic begins with A. Atropine begins with A. You know what atropine does. So A and anticholinergic, that's my clue for you there. And results in descending paralysis. Yes, top down. Unless it's the Millard-Fillmore variant.
That's for Guillain-Barré syndrome, right? So ascending paralysis is going to be Guillain-Barré syndrome or tick paralysis. Descending paralysis is going to be your botulism. But I didn't tell you this because they probably wouldn't ask on the road, but there is what's called the C. Miller-Fisher variant
That's
of
what
Guillain-Barré, which
Millard-
actually starts at the top and goes down. But they won't ask you that one.
Millard-Fillmore. The person, I think
Fillmore,
it
you're
is.
killing them.
Is it-
Okay, what's next? Give us another topic here.
Nephrology. is next
Nephrology.
there, Okay.
Okay, number 1 for nephrology. Which of the following is a cause of, is a pre-renal cause of renal failure? Which of these are pre-renal before the kidney? CHF, ATN, papillary necrosis, glomerulonephritis, or kidney stones? Which one of those is pre-renal? A, CHF. Everything else there is the kidney itself, right? So that's pretty easy. So the answer is A.
A 25-year-old presents with a 3-week history of lower extremity edema and fatigue, a massive proteinuria. Which of the following is the most likely diagnosis? Lipidemia, angioedema, who wrote these answers? Thrombotic diathesis, nephrotic syndrome, and Guillain-Barré. Well, you'd have to say nephrotic syndrome, right? Which is glomerular damage due to a whole bunch of causes like lupus or diabetes, but that common pathway is protein leak like crazy with associated edema.
Yeah. Plus, it's the nephrology section, so that's another hint that that's
Yeah,
probably the
absolutely.
answer for
All the
nephrotic
slides
syndrome.
have, if it has any
Just saying.
SP on the bottom.
Exactly. This one actually is related to the endocrine lecture. It's going to be covered in endocrine. We didn't cover this in the other lecture, so we should just skip through that one.
A 30-year-old dialysis patient presents with decreased blood pressure, distended neck veins, distant heart sounds, and equal lung sounds. A low-grade fever is present. Which are the most likely cause? This is a cool one. CHF, tension pneumothorax, pulmonary embolism, pericardial effusion, or Dressler syndrome. Pick one. So we're talking about pericardial effusion associated with this disorder. If it was a tension pneumothorax, you would have not equal breath sounds. Neck veins could be distended. Blood pressure could be low.
Yep. There's probably a uremic pericardial effusion, right, going on with
There
this
you
person.
go.
Okay, that's the answer. Okay, dialysis patient missed their last treatment, has a Brady asystolic arrest.
Ooh.
What of the following would be most beneficial during her resuscitation? A little more potassium? We like that idea? That doesn't seem like a good idea. Magnesium, phosphorus, calcium, bicarb. So what's going on, first of all? She's probably hyperkalemic, right? Hyperkalemic arrest, dialysis patient. What do we want to give her? Calcium, D. Good.
So you can know what kind of arrest a person has by which direction the wheelchair is pointing at the dialysis center. If they're wheeling them in and they have an arrest, it's a hyperkalemic arrest. And if they're wheeling them out, it's a hypokalemic arrest. So you look at the direction of the wheelchair.
I like that.
Thank you, very helpful.
That's
Thank
good.
you very much.
I'm gonna add that
Okay,
to my
which of the
chart.
penile lesions is classically described as painless? Come on, this is the easy one. This is the chancre syphilis.
Okay. Which is consistent
Ooh.
with renal transplants?
Ooh.
Okay, we're talking about renal transplant. So is it the least common solid organ transplanted? There's got to be some other solid organs that are transplanted less often than kidneys, right? Okay, so that can't be right. Hepatitis C, is that uncommon? Nope, pretty common. Look at C and D. Cyclosporin is contraindicated. Steroids are contraindicated. What do you think about those? No, we actually give them. How about cyclosporin is nephrotoxic? That sounds pretty good. There we go. You got it.
A dialysis patient is brought to the ED with sudden severe headache with vomiting. What is the likely cause of the patient's chronic renal failure and subarachnoid hemorrhage? Oh, so pick one. So this is the association between polycystic disease, kidney problem, and aneurysms in their head. It's just an association.
Number 30, number 9, 30-year-old patient is suspected of having epididymitis. Usual etiology: chlamydia, urethritis from nonoxyl 9, E. coli, Klebsiella, B. fragilis. What does this 30-year-old most likely have? A, chlamydia trachomatis, yeah. So remember the classic teaching, you know, under 35 STD, over 35 bacterial sort of thing. That really bummed me out. I actually remember this when I was like 35 plus a month. I was like taking some guy who had epididymitis, and I just kind of reflected for a minute. I'm like, oh my God, like I'm 35 plus a month. I'm like in E. coli range now. Like no one's even
Yeah.
going to consider an STD in me. It's like it's hopeless, you know. I was so bummed out. So anyway, yeah,
I think that this age thing is wrong here. I agree with you.
yeah, yeah. Good to hear that, Rick.
If I get this, I want it from gonorrhea. I don't want it from E. coli for
I
crying out
know, isn't that
loud.
ridiculous?
Rolling in my.
I know. That's just not right. VC, I mean, come on.
It's not right. Damn it. 10. Which of the following is true statement regarding imaging studies for ureteral stones? This may be a little dated. IVP demonstrates function and anatomy. Contrast reactions and nephrotoxicity are more likely to occur with non-ionic versus ionic. That's just flip-flop. Patients who are dehydrated, hyperglycemic, over the age of 70 are ideal candidates for IVPs. Yeah, no. Total obstructions induced by ureteral stones larger than 6 millimeters are poorly visualized on ultrasound. Ultrasound is the gold standard in renal stone imaging. So there's a bunch of long answers here. Which one do you like? You like A? That's true. I mean, we don't do this anymore, but that is the true answer.
Okay. Number 11, which of the following statements is true regarding ureteral stones? So let's just go through them. More common in females than males? What do you think? No, probably more men. Most uric acid stones are radiopaque. Now, that's probably the only one that's not radiopaque. Your calcium, your struvite, your cysteine, those are all radiopaque, so that one's doesn't sound good. Ureteral stones are less common in warmer climates. No, it's warm, you get a little dehydrated, you get your kidneys, that's probably not true, but we'll keep moving on. Few stones greater than 6 millimeters will spontaneously pass. That's sounding more reasonable. A big stone is getting harder to pass. And the UPJ, the ureteropelvic junction, is the most common location of obstruction. Is it the UPJ? No, it's the UVJ.
UVJ.
Ureterovesicular junction is more likely to do it. So our answer here, D. Big stones, harder to pass.
Oh, here's a hard one. Regarding dialysis-associated problems, which of the following is true? First use syndrome is manifested by hypertension from an anaphylactic reaction to a new dialysis. You could probably figure out that that's wrong. Dialysis-related disequilibrium is treated with corticosteroids. Hypokalemia is the most common cause of dialysis-related brachysystolic cardiac arrest. Just the out. Hyperkalemia in dialysis patients can be initially treated with IV calcium gluconate. We already said that. Dialysis dementia responds to increasing the frequency of treatments. Now, dialysis dementia is about aluminum and some vitamin or something.
All right, moving on. Which of the following is the most common cause of painless gross hematuria in patients over the age of 40. So painless gross hematuria. Vigorous exercise, well, that can certainly give you gross hematuria. It can. Kidney bladder stones, that's usually some pain associated with that. GU tumors, that sounds like a winner maybe. Let's look on bleeding disorders, coagulopathies. That can give you gross hematuria, but is that real common? I mean, not that common, right? How about Foley catheter insertion? Right. First of all, it doesn't cause a lot of gross hematuria. Second of all, you cannot call that painless. All right. So unless you were either paralyzed or you've got like the steel urethra or something for that to be called painless. So that does not count. So what do we like here? C, GU tumors. Absolutely.
Which of the statements is true regarding acute epididymitis? A positive friend sign is relief of scrotal pain with rotation of the testes. Which way in the northern hemisphere do you do that? Pain relief on elevation of testes is considered suggestive of epididymitis rather than testicular torsion. Epididymitis is most common in young prepubertal males. The etiologic agent is related to patient's age, is always caused by infection. No, some of the old farts get it from a urine backflow. But in any case, what would you pick out of these as your choices? You'd have to check, I think, B. Elevation relieves the pain of testicular torsion. No, that's not right.
Epididymitis.
Did I say that wrong?
Pain relief on elevation is considered suggestive of epididymitis rather than torsion. Yeah, it's not a really reliable sign anyway, frankly.
No, it isn't.
So
No.
you can just leave.
And the exam will not be using these names for these tests.
Right. Yeah, like the Prenz sign. Yeah, you can just stop lifting up the testes and just leave them alone. Be fine.
Let's go like this.
It's going to be fine. Leave them alone. Number 14 here. Number 15. A 14-year-old presents with acute onset of scrotal pain, diagnosed with testicular torsion. Okay, so we don't have to make the diagnosis at least. We got a 14-year-old with torsion. What's accurate regarding this? So 80 to 100% salvage rate if they're detorsed within 24 hours. Does that sound reasonable? No, way too long. Like, less than 6 hours was what we want to get done here. Manual detorsion generally involves rotating the testes from medial to lateral. Does that sound right? Medial to lateral. Kind of sounds right, but let's look at the other ones and make sure. Peak incidence is 6 years. What's a peak incidence for torsion? Yeah, adolescence, puberty, that sort of time. Testicular torsion, usually, the usual lie is vertical. Is it usual vertical? It's kind of horizontal. Remember that bell clapper deformity is what ends up happening? So the horizontal lie predisposes you to torsion. And abdominal pain is rare in torsion. You never have belly pain. Yes, of course you see belly pain. So the answer is B. Manual detorsion generally involves rotating the testes from medial to lateral. So what that means is it's the open book. You're going this way medially, and you're rotating it laterally. Okay, you're opening the book. It's hard to describe it that way, but that's what it is. You're opening the book for manual detorsion. Not the
But
other
that's
way.
only in the northern hemisphere.
It depends. That has to do with the toilet bowl and where it flushes,
exactly,
right? Got
exactly.
it. Okay, yeah, got it.
Which of the following is true regarding priapism? This is a pathologic erection involving glands and corpora spongiosum. SQ epinephrine is used to treat most reversible causes, subcutaneous. Exchange transfusions may be necessary for those caused by Viagra. Most etiology are veno-occlusive as opposed to arterial, and the basic treatment varies depending on the cause. So of these, I think that, D is probably the most reliable answer here. The blood goes in, can't get out kind of thing, so it's on the venous side. And all of them were basically treated with these alpha agents injected into the corpora cavernosum.
Okay. Which of the following statements regarding general urology is true? So I think we're going to make comments about the specialty of
General urology,
urology
the whole
now.
thing is right
Okay,
there.
so like, it's more common in men than women, this sort of thing. Okay, no. Okay, general urology. We're going to talk about urology here. Balanitis is inflammation of the foreskin. Posthitis is inflammation of the glands. Are those right? I think it's probably the opposite. Phimosis is a common cause of urinary retention. Well, I guess it could happen, right? Little slit, but it's common cause. Let's look at the rest of them. paraphimosis can be a true urologic emergency. That's true, right? You get stuck, you get some necrosis potentially there. Necrosis is not good there. Typical age for a penile hair tourniquet is 3 to 7 years old. Is it typically your 7-year-old coming around going, guess what, I got this hair wrapped around my penis? Probably not. A little bit younger is more likely there. So, answer? D. Say it one more time real loud. D, right. Paraphimosis is a true urologic emergency. So balanitis is the glands, posthitis is the foreskin. They got it backwards. Phimosis could cause urinary retention, but it'd be kind of tough. It's not real commonly, I guess. Usually it's not. Paraphimosis can be an issue. We got to get that reduced. There you go.
Which of the following treatments is true regarding Fournier's gangrene? Penicillin is generally adequate. It typically begins as a benign abscess and slowly develops into a more serious infection. No. It should be considered in any patient with scrotal, rectal, or genital pain out of proportion to clinical findings. Yes. IND is the usual ED treatment. No. Antimicrobials are unnecessary after surgical debridement. So the answer here, you know it, and you said it already, is C. Give me a couple others of pain out of proportion. Mesenteric ischemia, right? And one more. Necrotizing fasciitis. Did Angela say that? I don't think so.
I don't think so.
Necrotizing fasciitis is
compartment syndrome.
Compartment syndrome, okay. Any more?
Adult epiglottitis, right? Sore throat, really bad. You look in the throat, you don't see much because it's the epiglottis.
Below. We're going to do that tomorrow.
All right. Oh, there you go.
Oh, by the way,
Preview.
I should tell you, we should have told you, we have a disc of tomorrow's last 2 lectures for those of you who have to leave. It's from the course we did last year, which is similar to this course, if you need to leave early. So it'll be out there for all of you should you want to leave. Not that you would, of course, leave early.
We don't know why you would, but if you are, we have DVDs for you, okay?
You're going to miss a fabulous talk on oncology, hematology if you leave tomorrow.
They're sold now. There's no doubt about it. They're all staying.
I think it's 1% of the exam.
Right. Okay, which of the following statements regarding, oops, no, never mind, you just did that one. Which of the following drugs will not worsen contrast-induced nephropathy? So in other words, one of these is good and the rest are bad for contrast-induced nephropathy. Ibuprofen, furosemide, enalapril, N-acetylcysteine, and naproxen. Which one will, right? Yell it out. D, right? Right. So you got your NSAIDs there, your ibuprofen, naproxen. That's not good for the beans, right? Your diuretics, your ACE inhibitors. All those things are things that can predispose you. They're risk factors actually for contrast-induced nephropathy. But N-acetylcysteine is something that you can give, right, in high-risk patients or higher-risk patients to reduce the chance of getting contrast-induced nephropathy. All right? So the answer is D.
Which of the following is the cause of progressive, rapid progressive glomerulonephritis? Hypertension, chronic? No, that's rapid. Pyelonephritis? No. Lupus? Toxic alcohol overdose, diabetic neuropathy. So the answer here has to be lupus. This is this self-destructive inflammatory process. You immunologically destroy your kidneys, proteinuria, leak blood into your urine as well. Oh my God.
Okay, you did nephrology. I think we might have to go a little faster, Rick.
Is it possible?
Well, they might leave before tomorrow if we don't. So.
Which one are we doing here?
Let's try it. This is
pulmonary.
Pulmonary. Okay, let's do it real quickly. 75-year-old smoker, pleuritic chest pain, shortness of breath, just got an 8-hour car trip. What do they got? Okay, what's the test you want? Blood gas, D-dimer, venography, CT angiogram, or VQ scan? CT angiogram. You guys do this all the time. We'll leave it at that.
A patient presents with sudden onset shortness of breath, last menses that are on it now, endometriosis, breath sounds diminished on the right, heart rate 123, respiratory rate increased, blood pressure low, pulse ox low. What should you do? The diagnosis is catamenial pneumothorax, and so we're going to do a needle compression, B as the answer there.
Okay, 65-year-old has COPD. On ECG has some sort of a supraventricular tachycardia at 130. But the PR intervals are variable, and the P-wave morphologies are variable. So what is that? MFAT, so multifocal atrial tachycardia, right? Okay, what's the most effective treatment for that? DIG, low pressure, esmolol, verapamil, or do we just give some oxygen and nebs to this person? E, right. So basically, this is one of those where you treat the underlying condition, and it's probably going to go away. It's a transient dysrhythmia. Treat the underlying condition, and it'll go away.
But if you were going to give a drug, it would be, of course, magnesium. A
Rick's
64-year-old
favorite.
presents with a 3-day history of productive cough, fever, and chills, has a history of COPD and diabetes, was given azithromycin at his doctor's office. What additional antibiotic would be most appropriate out of this bunch? Community-acquired pneumonia, double treatment, older person, diabetic, at risk kind of thing. We would add to this maybe a shot of ceftriaxone out the door, maybe? You like that one? All right.
AIDS patient, cough and fever, CD4 counts 100, blood pressure, respiratory, heart, little tachycardic, pretty hypoxic there. Chest X-ray has bilateral interstitial infiltrate. So what do they have, first of all? Right, pneumocystis pneumonia. What do we want a treatment with? Bactrim, Zithromax, Bactrim steroids, pentamidine, ceftriaxone gent. So we know they got pneumocystis, so we're thinking Bactrim, but A and C, do we want to give some steroids too? Pretty hypoxic there, 91%. They probably got a PaO2 that's pretty low there. So yeah, so the best answer for this one is actually Bactrim and steroids. C.
Characteristics of PCP pneumonia in AIDS patients include which of the following features? A rash, maculopapular rash? No, if we were talking about the atypicals, this would go along with Legionnaires. Normal blood gases? Increased LDH, classic right upper lobe infiltrate with bulging fissure. That was equal to Klebsiella. CD4 count greater than 200. So you want to pick one of these? Yeah, there's this leakage of this. This is probably the best answer of those that are here.
78,
oh my God.
Oh my God. 78-year-old female has a cough for 4 hours after a choking episode at the nursing home. So she's at the nursing home as this choking episode, and now she's been having a cough for the last 4 hours. On exam, she's got a little bit of wheezing, some scattered bronchi. Chest X-ray is normal, but she's really hypoxic, 85% on room air. So first of all, what do we think she's got? Probably aspiration pneumonia. So what do we think? Is it a PE? Does she have aspiration? Well, we just said aspiration. That's probably right. Shouldn't she be discharged? Follow up in respiratory failure clinic? Does that seem like a good idea? Probably not. Antibiotics are indicated immediately. Do we need antibiotics immediately for aspiration? Probably not. Afebrile, maybe if she's febrile, you would. Patient should have a PEG tube placed? Yeah, maybe, but I think I'm not going to make that call. Aspiration, the answer is B.
45-year-old male presents in January with a cough, rust-colored sputum, that's a biz-buzz, pleuritic chest pain, fever, and rigors. Which statement is true? The etiologic agent is the most common for community-acquired pneumonia. Again, a compound question. Excellent prognosis despite non-treatment, and don't think so. This patient is most consistent with Legionella. No, Legionella is elder, they are sick for sure, but they don't have rust-colored sputum. Gram-strain, gram-positives, PMNs, and gram-negative diplococci, and gram-positive. Meningitis is not associated with this pathogen. Yeah, it sure is. But the best answer here then would be A, etiologic agent. We're talking about strep pneumonia, group A, not group A, strep pneumonia.
Number 9, 35-year-old HIV positive with a CD4 of 600. Cough, night sweats, and weight loss. Had a PPD conversion a year ago. So what do we think is going on with this guy, first of all? TB, what type of TB is going on with this guy? Positive PPD a year ago. Now he's got all these things. Reactivation TB. Okay, so what's the chest X-ray going to look like for reactivation TB? Diffuse interstitial changes, left pleural effusion, left upper lobe or apical opacity with cavitation, right lower lobe opacity with a hilar adenopathy, that's the Ghosn complex, reticulonodular pattern. Which one do we think? What's reactivation look like? Upper lobes, right, so C. So upper lobe opacity with cavitation. Remember, when TB reactivates, classically, it's in the upper lobes or the superior segments of the lower lobes, okay? So it's upper areas.
52-year-old presents with fever and cough productive of current jelly sputum. Patient has a history of alcoholism. Regarding the most likely etiology, which of the following is true? You just got to know this. More common in alcoholics and diabetics. Yep. Can be treated as an outpatient? No. Is not associated with empyema. That's what that big wedge thing is. Organism, gram positive, gram negative. Is only community acquired. So of these that you would pick,
Regarding PEs, which of these is correct? Negative Doppler ultrasound of the legs excludes a PE. Lower extremity DVT is not a major risk factor for PE. A negative CT can't rule out submental or subsegmental PE. That sounds pretty reasonable. Lower extremity ultrasound is a study of choice in pregnancy. Well, you could do it. I'm not sure it's a study of choice for PE. A normal blood gas excludes PE. That doesn't sound right. So what do we think is the best answer here? I would go with C. Negative CT can't rule out these basically smaller PEs, these segmental, certainly the subsegmental PEs. Those are the ones that it really can't rule out very well. C.
which of the following is typical for the diagnosis of Legionella in a 70-year-old man? GI symptoms, hypernatremia during the winter, pathology seen on gram stain, and a well-appearing patient. Well, it's hyponatremia, and it's not during the winter. And the reason that you can remember this is, I don't know if you remember the first episode of Legionella. It was in Philadelphia at the Bellevue Stratford Hotel in the summertime. They found it in the water thing, in the air conditioning thing, so it's in the summer. The pathology, you can't see this bug on a gram stain, and the patients are quite sick. They're elderly and very compromised. So of these, the answer actually is A.
Number 13, 6-month-old presents with new onset wheezing in association with some fever and rhinorrhea. The chest x-ray shows some hyperinflation. Which of these is true? What do you think they have, by the way? Yeah, probably bronchiolitis, right? So the likely cause is RSV. Sounds pretty good. Steroids are essential. Nope, they don't really work for RSV. Chest x-rays are usually very abnormal. Nah, a little hyperinflation. Antiviral therapy is routine. No, ribavirin is not recommended anymore for this, at least certainly routinely. Albuterol is never beneficial. Hey, you can't say never. You got to give it a try. Every once in a while, someone gets a little better from it, right? So the best answer here was A. It's RSV bronchiolitis.
Oh, that got through quick. A 6-month-old presents with significant new onset wheezing in association with chest x-ray and rhinorrhea. Chest x-ray shows hyperinflation.
That's what I just did. That's what I did. Skip. There you go.
Never mind.
But they were going to get it right on the first bat. They were on it.
That was Roseanne.
Never
I was
mind.
just seeing if they're paying attention.
That's right. It's good.
Oh, God. Treatment of anthrax would include any of the following except. So I guess we'd have to pick pentamidine, which is not used for the treatment of these bacterial disorders for sure. So let's go just with C.
And you'd be right. Which of the following most appropriately describes psittacosis? So mostly in the southwestern United States. Hyaluradenopathy is typical on the chest x-ray. Associated with hepatitis, also known as Coxiella burnettii. Associated with bird handlers. Which one are we going with?
I heard the bird.
Going with the birds, going with E. Right, so southwestern U.S., A and B are both what? That's Coxie. That's coccidioidomycosis. C and D are Coxiella burnettii, which is also called what? Q fever. That's Q fever, okay? So the bird handlers is the psittacosis.
You know a lot of stuff, Peter.
No, I'm just telling you what's on the slides. That's what it is.
A 21-year-old asthmatic presents in severe distress. The patient is intubated. Which of the following is true regarding permissive hypercapnia? It is intended to reduce barotrauma. That sounds good. Respiratory acidosis is not tolerated well by mechanically ventilated patients. Well, that's not true anymore. Achieved by reducing the expiratory time of the ventilatory cycle. Achieved by increasing so they can breathe out slowly. Rapid normalization of the PCO2 is critical. Now, we can let it rise. That's what the whole thing is about. Pulse oximetry reading should remain 100. Now, you don't need to be that high. So of these, the answer would have to be, we don't want to do barotrauma anymore.
Okay. Which type of patient is more likely to demonstrate cyanosis? Sickle cell, COPD, chronic renal failure, pregnancy, or CO poisoning, carbon monoxide poisoning. So I thought this was a little tricky at first. So just think about your practice. Let's just start with that. You see patients all the time. Which one's got cyanosis of those? Your COPD patient, right? So the answer is B, it's COPD patient. But now the question is why? It's just to think about this a little bit. Remember, to get cyanotic, you have to have, deoxy, basically desaturated hemoglobin. So you have to have enough hemoglobin to begin with on an absolute level so that some of that can be desaturated. So if you're anemic, anybody that makes you anemic, you don't have a lot of hemoglobin to begin with, so it's harder to have the critical amount that you will see to have cyanosis. So anything here that's associated with anemia isn't going to do it. So sickle cell, renal failure, they're anemic. Pregnancy, that can be anemic. Carbon monoxide poisoning, that's not anemic, but basically remember carbon monoxide looks just like, it doesn't pick up in your pulse ox. It looks like oxyhemoglobin, so that's not going to give you deoxyhemoglobin, so that's not going to do it. But COPD, they actually even have more red cells, right? They can be polycythemic. So they got kind of a bigger denominator to start with, so you might be more likely to see cyanosis. So it just makes sense just from our clinical practice, but that's the reason.
That was extraordinarily lucid.
And surprisingly, probably.
I'm shocked. Come on, this machine here needs a new battery. A 3-year-old presents with an acute onset of coughing, has a mild bronchospasm, unresponsive to albuterol, has no URI symptoms, chest X-ray, hyperinflation on the right side, and loss of volume on the left. Which of the following is true regarding the likely cause of this cough? Patient has a foreign body on the left, tracheobronchitis, atypical pneumonia, left-sided pneumothorax, or a foreign body on the right. So this is this air trapping that you get kind of thing we talked about. So the answer here would be E.
Okay, 78-year-old presents with a new pleural effusion. They do a thoracentesis. Which of these things is consistent with an exudative effusion? So remember, exudative effusion, does it have lots of junk in it or not so much junk in it? Lots of junk in it. Okay, so protein less than 3, the protein ratio is less than 0.5, white cells less than 100.
This is too hard.
We don't like the less than things.
I'd
LDH greater than
I'm
200,
just passing this question.
glucose greater than 100. So which one is it? D, right, it's the LDH greater than 100. Remember, exudates have lots of gunk in it, so all the ones with the lower, that can't be it. It's going to be one of the higher ones. So is it the high LDH or a high glucose? Well, what do we send these things off for generally? It's your LDH, right? So high LDH is the answer for this.
I'd have passed. The superior vena cava syndrome, we're going to have a good time with this tomorrow, is a manifestation of non-Hodgkin's lymphoma of the chest, associated with ptosis and anhidrosis on the affected side, associated with increased intracranial pressure, results of hypertensive crisis, a self-limiting disease process. So this is basically about lung cancer, blocking off the return of blood from your head, causing you to have intracranial hypertension. And so what answer would be here? All the symptoms would be associated with increased ICP.
Good.
Do you?
Next section.
We could do a bonus and not do the last section. No.
You're the boss, my friend. Whatever you tell me.
Oh, God. Peds. I think, what happened to cardiology?
That's next.
Cardiology should have been done early. It was the first one we did this morning. It's the first lecture.
But it was
Okay, all right. Pediatrics, here we go.
Okay. All but one of the following is classically associated with a mechanical cause for vomiting in an infant. So we're looking for the thing that is not mechanical on this list. Bilious vomiting, that's probably malrotation, mechanical. Projectile vomiting, what's that? Pyloric stenosis, that's mechanical. A tender, tense mass under the diaper, that just sounds mechanical, even if you don't know what it is. What do you think that thing is, maybe? Maybe a hernia on that one, but it's a good thought. It could be that. Under the diaper, mass under the diaper. Okay, could be an interception, who knows? Low glucose and metabolic acidosis. There's nothing mechanical sounding about that, right? Current jelly stools, there's your interception for sure. So the answer for this is D, right? So everything else is mechanical. Everything else is plugging things up.
Which of the following is consistent with a high-risk ALT? Awake child, hypertonic and rigid. These are just the opposite of what the hypoxics are. No associated seizure activity and associated with feeding. I mean, remember the aspiration kind of thing? We didn't think that's a big deal, but it is. So it's associated with feeding.
Okay, here we go. 2-year-old, lethargy, fever, and seizure. You do your LP, and in the process, you get a surprise, first episode of bloody diarrhea. What's causing this? You got a bunch of choices here. Rotavirus, Salmonella, Shigella, E. coli, or enterovirus. What do you think the answer is? Shigella, exactly. We covered this before. So the viruses aren't causing bloody diarrhea. The other things can. And the one that's associated with seizure, remember, is Shigella.
A neonate presents to the ED with jaundice. Which of the following considerations is the most important in determining the need for admission? The presence of greater elevations of direct reacting bilirubin in comparison to indirect reacting bilirubin. History of breastfeeding, negative Coombs. We'll talk about Coombs tests tomorrow. Lack of evidence of hemolytic antibodies. This is basically Coombs. All of the above are similarly important. So, I try to emphasize this very much. This is answer A, yes?
Number 5, 6-month-old, low-grade fever, cough, wheezing, and a little bit of intercostal retractions. Sounds pretty similar to what we've heard before. No family history of asthma, no foreign body aspiration. What's true about this? So once again, what do they have? Again, probably RSV bronchiolitis. So NEBs are highly effective. Not right. Addition of ipratropium is substantially helpful. Now, risk of apnea is directly related to the severity of disease. That kind of seems like it ought to make sense, but I don't know if that's right. Let's move on. Heliox is contraindicated. Well, it certainly wouldn't be the first thing I'd go for, but I'm not sure I'd say it's contraindicated per se, although whatever. All admitted cases need isolation. Yeah, you got to admit the RSV bronchiolitis. So we're down to this C and D that both are kind of making us wonder. But what is the thing that is most likely predicts apnea? It's not the severity of the disease, it's young age. So the younger they are, the more likely they are to have apnea. It's not really the severity of the disease. So
I skipped that in the talk, but this is an important point, and Peter's right on. So apnea is a little scary thing about this because it's not related to the severity. So you can send a kid home who has this, they could stop breathing.
And it's why the younger ones are the ones that you want to bring in. Even if it's not as severe, it's the real young ones that you need to be watching.
A 15-year-old with cystic fibrosis comes to your ED with what appears to be a severe chest infection. Which of the following is most typical of these patients? They typically have a pink puffer pathophysiology in distinction to blue bloater. Bronchospasm is a primary pathology in these patients. Respiratory failure is common in terminal patients. Dehydration with concomitant hyperchloremic acidosis often accompanies other pathology in these patients. Dysfunction of exocrine glands is the core pathology in this sex-linked genetic disorder. So that answer has a couple of components. So one part is right, the other part is wrong. That means the whole thing is wrong. So E's wrong. When we talked about loss of chloride, we talked about chloride, hydrochloric acid. If you lose chloride, you become hypochloremic, not hyper. You become alkalotic, not acidotic. Respiratory failure is what these folks die of. Bronchospasm, not necessarily. And they're the blue bloater pathology. They're right ventricular issues, right ventricular strain, evidence of right-sided failure.
Okay, regarding pertussis, which of the following is most correct? So we don't have to make the diagnosis. It's pertussis, very simple. Okay, does vomiting frequently precede the coughing paroxysms? Now, it's usually the opposite, right? You cough, 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 and get post-tussive emesis.
I didn't mention that either. I'm sorry very much.
Rarely lasts more than 2 weeks. Remember, this stuff starts lasting for a long time. Do most patients develop the inspiratory whoop? It's called a whooping cough. Do most patients have it? No, most really don't have it. Complications of increased intrathoracic pressure include rectal prolapse. Sad but true, okay? That can happen. All that coughing, all that increased intrathoracic pressure can give you rectal prolapse, but more commonly, it gives you subconjunctival hemorrhages or a bunch of facial petechiae or things like that. Are kids the primary reservoir? No, they're more likely to get the disease, but who's the reservoir?
We.
It's the adults, right? It's us that are the reservoir. So the best answer here is D.
Concerning pediatric meningitis, which of the following is a true statement? Listeria is most common after 2 months of age. Steroids are unequivocally beneficial, particularly for decreased mortality for strep pneumoniae. And meningitis is associated with the highest mortality. Chemoprophylaxis is appropriate for contacts of patients with most forms of meningitis. And group E strep is acquired from the mother. These are a bunch of complicated answers, but the one that is most straightforward, and you don't have to think about too much, is the last one, yes? Group E strep is from mom.
Okay. Patient with a VP shunt presents to your ED. What things should you remember? Headaches may represent shunt dysfunction with decreased intracranial pressure. That doesn't sound right. Shunt dysfunction, but not decreased ICP. Fevers in patients with shunts should cause one to consider meningitis, which is generally caused by enteric pathogens from the gut. Are it usually gut pathogens? That's usually more skin things going on, right? Okay, resistance to compression of a pumping chamber is consistent with the shunt obstruction. That sounds kind of right. You should be able to push on it and refill all that sort of stuff. So if it's not doing right, that's kind of could be a shunt obstruction. That sounds pretty reasonable. Let's make sure the other ones aren't better. As with benign intracranial hypertension, the ventricle size is usually normal in these people with shunt obstructions. Is it usually normal? Nope, it's big. Most fevers with associated shunts occur more than 6 months after their insertion. Nope, it's usually less than 6 months. Actually, usually probably less than 2 months or 3 months. It's usually pretty early. So the best answer here is C. Good.
A 15-year-old presents with recurrent headaches over a 6-month period. The CT scan and CSF are normal except for pressure is elevated. We got this twice now. What would you expect to be additional considerations in this case? So we know what we're looking for in terms of this idiopathic intracranial hypertension. The patient can be expected to be a thin male. It's really chubby female. Papilledema may be present on the eye exam. It will be present. Acetazolamide, furosemide, or steroids are contraindicated. No, the idea is that, diuretics can be considered a good thing, especially acetazolamide. Is rarely associated with tinnitus. No pulsatile tinnitus. It's the biz-buzz. Visual acuity is a more sensitive measure of the progression of the condition than is visual field testing. I think it's probably the other way around. So the answer here, papilledema may be present. Papilledema will be present on the eye exam. That's why the eye exam is so important in these cases.
Okay, which of the following can be clues to the diagnosis of recurrent generalized seizures in a previously well afebrile child? So you got some kid, they're having these recurrent generalized seizures. Which are clues? New positive PPD in a family member who lives with the child. What's going on there? INH overdose maybe, right? Okay. A belief that forcing plenty of water will abort or treat childhood illness. What could that be doing? Hyponatremia. Okay. A 60-year-old uncle lives with a family who had an amputation of the right foot. Wonder why he had an amputation of the right foot. Could he maybe be diabetic? Could he maybe be on some oral meds that cause hypoglycemia that causes seizures? That seems reasonable too. Okay. A rhythm strip that shows a markedly prolonged QT interval. Even if you don't know the answer, I mean, there could be lots of drugs or meds that do that, but hypomag could do that as well, right? So the answer, best answer here, all of the above. All of those things could be clues. You got your INH, your hyponatremia, your glyburide, your hypomag, or something else. All of those are clues.
A 4-year-old child with episodic severe abdominal pain for the last 3 hours, as the ultrasound noted. What is a frequent associated finding with this disorder? There's a protruding mass into the bowel lumen, a palpable mass in the left lower quadrant, bloody, very soft stools is an early finding, is a rare cause of bowel obstruction in a young child, is associated with projectile vomiting. So we know that last one is definitely not correct. So this picture is the tube within a tube, and this is basically intussusception. So the answer here that is most reasonable, a protruding mass into the bowel lumen. Remember, lead points, those kinds of things, Meckel's.
Yep. Number 13, which of the following is appropriate therapy for TET spells in the setting of tetralogy of Fallot? So someone's got a TET spell. What do we want to do for them? Do we want to increase peripheral resistance, increase venous return, increase ventilatory efforts, avoid bicarb, or avoid sedation? So what's the thing you want to do? A, increase peripheral resistance. So basically you want to, remember that with your TET spells, you've got, right to left shunting. You're trying to want to do something to get more blood going to the lungs here. So you want to increase peripheral resistance. So you move things from the left back over to the right and get blood going back through the lungs. So this is what you want here. You got your knee chest position, increase peripheral resistance.
Henoch-Schönlein purpura and hemolytic uremic syndrome have which of the following characteristics in common? This is a tough one. Both are associated with low platelets. Both are associated with characteristic skin lesions. Both involve kidney dysfunction. Both are caused by bacterial infections. Both have abnormal PTTs. I think the easiest answer would be just to go right to C, but you should be able to try to figure out these others in terms of the pathophysiology of these two disorders. Both of them are immunological processes, but that's kind of where it ends in terms of how they work and how they screw you up.
Okay, a 4-month-old child presents with inconsolable crying. What's most true about this? Taking off a diaper may reveal multiple causes of inconsolable crying. What do you think about that one? Yeah, that seems pretty reasonable. We're going to come back to it, but that seems very reasonable. Colic is caused by feeding-related problems? Not really. Assessing an infant for the presence of a corneal abrasion is routinely, easily accomplished by a single provider. No problem.
I didn't even go there.
Send the med student in, no problem, you can do it, go get it, that sort of thing, right?
There will be fluorescein all over except in the kid's eye.
Pain caused by a volvulus is associated with bilious vomiting. That doesn't sound right. Pain associated with an intussusception is characterized by constant, unrelenting crying. No, remember they've got the intermittent, right, as it's kind of going on and off sort of thing. So I think our gut was right. Taking off a diaper may reveal multiple causes of inconsolable crying. So what might they have? Hair tourniquet, bad diaper dermatitis, some abuse or a burn, testicular torsion, hernia, right?
Anal fissure.
Anal fissure. Lots of stuff under that diaper. Look under the magic diaper. You might find something.
Which of the following is true statement regarding pediatric gastroenteritis? A check for hypoglycemia should be routine in patients with gastroenteritis. Well, that's a little bit of an overstatement, but moderate dehydration should routinely be treated with an IV. No, that's mild and moderate, or the SIPI. Because viral enteritis is caused by viruses invading GI cells, a cold blood is routinely found in these cases. Well, that's interesting because viruses do invade cells, but in this case, they don't generate blood. They don't destroy the cells the same way that Salmonella and Shigella do. Age-appropriate diet should not be instituted until it is clear the child can tolerate the brat diet. I specifically said, don't bother with that. That's old history. Dehydration should be treated conservatively. Half of deficit over 8 hours, the remainder over 16 hours. We're talking about rehydration in 4 to 6 hours, AAP guidelines. So the answer here is, 9%, 10%, or will be hypoglycemic. It's an easy check.
Okay, 20-kilogram child presents with dehydration. What's the approximate maintenance fluid? This is not resuscitation fluid, but maintenance fluid for 24 hours in a 20-kilogram child. So this is where you have to know the formula. You can't pull out your iPhone, which some people like to do, but you can't on the exam. So you got to know the formula. Half a liter, 1.5, 2, 2,500. Let's just go to the next slide so we can do the formula together, because nobody's going to remember this right off the top of their head without looking through it. So here's the way it works, right? 100 cc's per kilo for each of the first 10 kilos, right? So the first 10 kilos, that means you got a liter. 50 cc's per kilo for each kilo in the second 10, right? So we got 20 kilos. So those next 10, you get another 500. So that should give us 1.5, and there it is. So it's 100, 50, 20. You just got to remember that, unfortunately.
A child is clinically dehydrated. Which of the approximate fluid deficits are correct? Well, I didn't really go into the percentage because I think that's very kind of, you don't need to do it. So mild is 50, moderate is 100, severe is 150, and that's exactly, you know, the ballparks that you need to be in. So all of those statements are true. And this should be not, between Peter's 3 and these 3, you got pediatric fluids, I think.
Okay, which of the following is true regarding pediatric cardiac arrests? Most are VTAC or VFib. Kind of sounds like adults, right? Dopamine is the inotrope of choice. What do we want? Epi. Early drug therapy has been determined to be an essential part of successful resuscitation. No, manage the airway, that sort of stuff, CPR, et cetera. Contrary to adults, bicarb is also associated with improved outcomes in kids. No, bicarb is not really helpful too much for anybody. EMD, electromechanical dissociation, otherwise known as PEA, right, can be associated with decreased breath sounds on one side and tracheal deviation away to the other side. What might that be? Right? Tension pneumothorax, does that sound like that could cause PEA or old EMD? That's sounding pretty good. So I think we're going to go with E.
This is clearly an extra credit question. We didn't really spend any time on the APGAR score. But you want to get an APGAR score here in this kid? Neonate, heart rate 90, strong respiratory efforts, decreased muscular tone, bluish extremities, feeble cry. What do you think? They all have the chart, so this is not something that you would need to memorize, but they are things that you should, that we're interested in looking at in these kids.
I think the other thing with this that's helpful on some of these things, you know that the scale's a 0, 1, or a 2. So you look at the thing and you say, is it normal? Is it kind of bad? Or is it like really bad? If you want to figure out how many points you want to give it, right? Heart rate of 90, well, gee, you know, at least they got something going there. Strong respiratory efforts, that sounds pretty good. Decreased muscle tone, well, they didn't say it was gone. That sounds middle. Bluish extremities, it's just the extremities, not like totally blue everywhere. Feeble cry, hey, at least they're making some noise. So, you know, if you just kind of logic through some of these things with the APGARs, just realize it's, you know, it's either really bad, really good, or something in the middle. Okay.
Thank you.
Except for cardiology. Are we doing cardiology?
You want to do cardiology?
Or do you guys want to go home?
What's that?
Do
it
it?
tomorrow. We're out of here tomorrow.
Yeah. All right, well, listen, you can vote with your feet. Nobody has to stay here. Like, we're not taking attendance, all right?
We don't want to be accused of shortchanging anybody.
Okay, so
we'll do this if only Angela is here.
That's right.
Great. All right. No, we're not doing Durham. We're doing cardiology.
Cardiology. Would you mind handing me the water there? You got the aisle seat. I got the, you know, I don't get the access to the water, you know? Thanks, Rick.
When did we start this?
We're that much over. We
That's only an
we
hour.
started at 6. We've been going for an hour and 10 minutes.
I'm impressed. Gonna pull an all-nighter.
Let's go. Which of the following is consistent with variant angina, Prinzmann's angina, variant asthma? ST depression? No. Usually comes on during exertion? No, that's usually the regular angina, right? Most patients have some mild evidence of CAD on angiography. That sounds pretty reasonable. It never results in an MI. Can't happen, impossible. That doesn't sound right. Patients undergoing cardiac cath are rarely diagnosed with variant angina. No, I think the point here is that sometimes it's really hard to tell, and you do the cath and you say, yeah, guess what? It was variant angina. It was just spasm. There was no occluding lesion here. So the best answer here is C. They oftentimes have a little bit of underlying CAD that they spasm around.
Which of the following statement is true regarding aortic regurg? Results in a decrescendo systolic murmur. This is diastolic. This is responsible for producing a water hammer pulse and Austin Flint murmur. That's an absolutely terrible answer. We're talking about basically a bounding pulse and a diastolic murmur, blood coming back, hitting the mitral leaflets. So that actually is going to be the right answer. Endocarditis prophylaxis and afterload reduction are generally not indicated. No, they are. It's never associated with Marfan. Marfan is connective tissue disorder. This is associated with aortic dissection. EKG reveals RVH. No, this should be LVH because basically pushing out comes back, pushing out comes back, pushing out comes back. So that's the answer. But I don't like these terms. We don't know what a water hammer is. Do you know what a water hammer is? I do. But I won't tell you.
I'm very disappointed, Rick, but okay. Patient had an MI 3 weeks ago, now has chest pain, worse with swallowing, fever, and a pleural effusion. What's the preferred treatment? So what do we think they probably have? Right, so this is a post-MI pericarditis, right? This is Dressler syndrome, usually occurs like 2 to 8 weeks after acute MI. So how do we want to treat this post-MI pericarditis? Back to the cath lab, NSAIDs, nitrates, antibiotics, or maybe a little thrombolytics will work. What do we want? B, NSAIDs, right? Pretty straightforward.
Patient presents with a regular pulse at a rate of 220. The patient's BP is 135/80. A delta wave is noted on one of the patient's old EKGs. Which of the following is the most appropriate for this situation? Well, I think that there was an old answer, and now there's a new answer. The new answer is all of these are fine because this patient has a regular rhythm. This is not a fib. If the patient had delta wave history and rapid AFib, the answer would be, drug-wise, anybody procainamide, yes, or amiodarone, those two.
Okay, now we have a patient with an irregular rhythm with a rapid ventricular response of 120. So what's that usually? Irregular, usually. It's AFib, right? It could be multifocal atrial tachycardia, but this is probably AFib. Rapid ventricular response 120, but later increases to 220. Has a known history of WPW also. Blood pressure is 100/60. What should we do now? So basically got somebody, they got WPW, they got AFib, they started at 120, but now all of a sudden they went up to 220. What happened? They started using the bypass track. So before they were going down the AV node and it was a nice filter there, blocking some of the beats and only let 120 a minute through. But now, boom, they're up at 220. They're going through this bypass track. What do we want to do? Amiodarone, DILT, procainamide, zap them, or adenosine? So this is a tough one here. So that's right. So is this stable? Is this unstable? That sort of thing. So if they were stable, procainamide is usually the right answer, right, for AFib in these patients. But, I mean, geez, this guy just went from 120 to 220, going down his bypass track. You're pretty sure about that. How do you know that while you're getting that drip ready, he's now not at 250, 300, and now VFib right in front of you? So this one, I think you ought to just go with the juice. And the answer is synchronized cardioversion.
Classic EKG findings of hypothermia are a delta wave, prolonged intervals, J wave, Osgood-Schlatter wave, and the asystole.
This one here, right?
That's right. That's right. So this is too easy. This is the J wave, takes off at the J point of the joint of the SC segment and the last part of the QRS.
Okay. In non-embolic limb ischemia, which of the following is the last sign to develop? So this is not where you threw a big clot and boom, everything's got broken off. Here you're having some ischemic limb ischemia. Pain, pulselessness, pallor, paresthesias, or coolness. Which of those is kind of the hardest to get? What's the last thing to show up, you think? Pulselessness, exactly, right. Yeah, that's pretty a late sign for a lot of things. So the answer is B, pulselessness.
So a patient presents with blood pressure of 260, 150, wow, dyspnea and chest pain. Which of the following agents is most likely to be successful for reducing this patient's blood pressure? So, I'm going to mention this. This is basically about giving nitroprusside, quick on, quick off, titratable kind of thing. Does do vasodilatation, and so there's this idea of giving some beta blockers in association with this reflex tachycardia. So the answer here is going to be B, rapid titratable drug.
Number 9, all right, this is about endocarditis. Which is true? Is the pulmonic valve the most commonly infected valve for endocarditis? No, it's probably the mitral valve, right? And if you're an intravenous drug user, it's probably the tricuspid valve. But overall, it's a mitral, intravenous drug user, tricuspid. But pulmonic valve, come on, it's not the pulmonic valve. It's not that. We know that's not right. Okay, a murmur is heard in less than 5% of the cases. Well, maybe by me, because I got like horrible ears, okay? But most of the time you got endocarditis, you probably got an associated murmur with it. It's certainly not less than 5%. Optimal antibiotic therapy is a first or second generation cephalosporin. That doesn't sound right. What sort of bugs are we talking about here? Right, staph, right? Maybe some, staph epi, one of these sorts of things, Staph aureus. No, you're gonna need some Vanco maybe. TEE, transesophageal echo, is considered the gold standard for detecting valvular vegetations. That sounds like a pretty reasonable thing. You're looking pretty close there. Let's look at the valves. Roth spots are noted on the palms and soles. Ooh, don't you hate that one? That just hurts. You actually got to know these things. So that's actually not right. Roth spots are the ones in the retina, the retinal hemorrhages. So if you remember Osler nodes, you probably already went over this, right? Osler, ow, those are the painful lesions that are on your tips of your fingers and toes, so Osler, ow. Retinal hemorrhages, Roth spots, those are both the R. So Roth spots are the retinal hemorrhages. And then the Janeway lesions, those are the other ones that are left. They're the non-painful ones, hemorrhagic lesions on the palms, okay? So Osler, ow on the fingertips and toes. Roth spots, retina, and Janeway lesions are the other ones. So here, the answer is D.
This is too easy. Which is the following cause of MIs?
That was too easy. I was like, wow, no discussion there. Okay, also easy. Which is consistent with unstable angina? Positive cardiac markers, chest pain is relieved by rest and nitroglycerin, ST elevation, chest pain at rest, or unchanged frequency and severity. Which of those sounds like unstable angina to you? What is it? Say it loud, someone. D, exactly. Chest pain at rest, right. Okay.
A 65 diabetic presents the ED with chest pain, troponin and MB are normal, EKG, sinus rhythm without ischemic changes. Which plan is the most appropriate? Discharge the patient as his markers and EKGs are normal. Repeat a second set of markers and discharge if normal. Admit the patient to rule out ACS. Administer thrombolytics. Perform a CT to rule out a PE. So I think the point that this is making is just because you don't have an MI, whether it be ST elevation or not, this doesn't rule out this pain this is the first manifestation of acute coronary syndrome kind of thing, angina, new onset angina. So it would be reasonable for a 65-year-old diabetic to come into the hospital with this. Agreed? Yes.
Okay.
I heard you, Angela.
That's right. Yeah, I mean, and the reality is a lot of these patients in practice, people get serial cardiac markers and either do some either further diagnostic testing or send them out with close follow-up for further diagnostic testing. But at least in this question, I think they're trying to lead you to, this is somebody who's sicker, somebody who's higher risk. Maybe we ought to just be conservative and do the right thing for them. All right. 72-year-old man presents with an MI, has third-degree heart block, and ST elevation in leads 2-3 in AVF. So that's an inferior STEMI, right? So we got an inferior STEMI with third-degree heart block. Has a little bit of brief VTAC, goes away. What do we want to say about this? What's true? Are these reperfusion dysrhythmias? No, we didn't reperfuse the patient, so it's kind of hard for it to be a reperfusion dysrhythmia. Immediately needs a transvenous pacemaker. Now, heart block, I mean, you think pacemaker, it sounds kind of good, but I'm not sure that's the first thing or the immediate thing this person needs with this inferior MI. Third-degree heart block is associated with a poor prognosis in anterior wall MIs. That probably sounds true. If it's an anterior MI and you're like necrosing off your ventricle and things like that, and you got heart block, that's probably bad. That sounds reasonable. Thrombolytics will not be effective. Can thrombolytics work for an inferior STEMI? Yeah, they can work. The patient should be treated with IV lidocaine. That's just silly. That's not going to work, right? That can't be the best answer for this. I mean, it's not right. So what's the best answer for this one? I think C, right? Third-degree heart block is associated with a poor prognosis here. So, I think the idea here is that it's an inferior, STEMI and that oftentimes can be associated with some bradydysrhythmias, including heart block, and if you reperfuse them, things might get better.
So what is an absolute contraindication for thrombolytic administration? I don't think, honestly, that this is something that would be a memorizable thing. Obviously, CVA for 6 months is made up. I mean, it's not like a randomized double-blind. We came up with that. So of these, and the spinal surgery thing, that was also made up. That's 2 months. So the answer here is A. We give thrombolytics for menstruating women all the time. Coumadin is not an issue here if you're treating the heart. If you're treating the brain, it might be a different story.
Right.
All right, come on.
Okay, 45-year-old patient presents with chest pain. ECG shows sinus rhythm, ST elevations, and 2, 3 in AVF. Sounds interesting. So we got, again, an inferior STEMI. Blood pressure 90/60, so they're hypotensive. Lungs are clear, but there's some JVD. Okay, so they're not in pulmonary edema, but there's some JVD and they're hypotensive. What's the most appropriate next step based on the most likely diagnosis? So what's going on here? Inferior STEMI, hypotension, and some JVD. What do you think is happening? Exactly. So this is a right ventricular infarction. You could get some right-sided leads to confirm it, but this is probably an RV infarction. So the RV is not pumping real well and filling the LV really well, so you get hypotensive. So what do we want to do for this right ventricular infarction? By the way, they're hypotensive. Do we like anything that's got the word nitroglycerin in it? The pressure 90, that's probably not good in any of these. So we can take out A, C, and D because they got nitroglycerin in it. So do we want to give aspirin and some normal saline, or do we want the intra-aortic balloon pump? What do you want to do? How about some aspirin and normal saline? Absolutely. So you give some aspirin, give them some normal saline, and try to fix this up, and oftentimes it's fixed with the normal saline.
This is clearly an extra credit question. We'll cover this actually tomorrow in the rheumatology section, but it was, so subcutaneous nodules is not, so that's, is not. Sydenham's chorea, arthritis, carditis, erythema, migraines. Well, even if you didn't know the other four, you know that erythema migraines is from Lyme disease. So that's got to be the answer that we're going to choose here.
What's erythema marginatum? Is the one that they're
Marginatum,
referring to,
basically,
right?
actually, it's interesting because erythema marginatum in many ways is described as very like the lesions of Lyme disease in terms of a rash that spreads out, central clearing, and there are multiple of these, and they convalesce and they form like a snake-like kind of thing. So that's kind of the genesis of the. Did you know that erythema?
Who knew?
Marginatum.
Marginatum. Very good.
Marginatum.
Very good. Very good. Moving on here. Okay, number 17. Exertional syncope, dysrhythmias, cardiac ischemia, sudden death. What does that sound like? Which of these things? Pericarditis, restrictive cardiomyopathy, hypertrophic cardiomyopathy, dilated cardiomyopathy, or amyloid? What's that sound like? Yell it out. Come on, you guys know it. C, hypertrophic cardiomyopathy. That's exactly right. You got this big old septum, right? Reduced outflow, and you can get syncope, you get dysrhythmias, you can get ischemia, sudden death. The athletes who are dropping on the court, as you're exercising, it's pumping harder and harder. The outflow becomes worse and worse. So that's hypertrophic cardiomyopathy.
Exertional syncope in a 70-year-old, you think of aortic stenosis. But the biz buzz is
Hypertrophic cardiomyopathy. Exactly.
56-year-old, blood pressure 190, 115. Wow. The patient has no complaints. What's he doing in the ER? Excluding mild frontal headache, normal PE. Which option is appropriate? Giving some medicines, follow-up as needed, or reassurance and defined follow-up. Well, you don't. In this case, A would be fine. You have to have defined follow-up. You have to acknowledge that there are vitals that are outside the range of normal. It is not believed that these, the headache and blood pressure are related, but so the answer here, the best answer is to do defined follow-up and do nothing. Certainly, Amo mentioned that you could start some mild diuretics or a ACE inhibitor or something like that, but the fact of the matter is that measuring blood pressure and defining hypertension is not a one-time kind of thing. It's got to be measured several times. But anybody that's got 190 over 115 is likely that it's going to stay elevated. And come on.
One more. 64-year-old patient, chest pain and shortness of breath. On exam has JVD, has some RALs, it has dyspnea, so we got some pulmonary edema going on there. Grade 5 out of 6 holosystolic murmur radiating into the axilla, okay. ECG shows an acute anterior wall MI, okay, I wish you told me that at the beginning, but that's fine. Chest x-ray shows pulmonary edema. So what's the complication? So we got somebody who's got an anterior wall MI, is in pulmonary edema, and has got this big holosystolic murmur going on. What do we think has happened here? Is this Dressler syndrome, aortic dissection, an ASD, chordae tendineae rupture, or a pericardial effusion? What's going on? D, chordae tendineae rupture, right. So this murmur is what? What's the murmur of? It's acute mitral regurgitation, exactly right. So they basically got their anterior wall MI, knocked out their chordae tendineae, basically so that it ruptured, and you've got acute mitral regurgitation, putting them into pulmonary edema.
And last, 74-year-old male presents with a acute onset of mid-abdominal pain, radiates to the right flank, history of coronary disease, blood pressure 80 over 40. What is the most appropriate next step for the most likely diagnosis? So the diagnosis is rupturing aorta kind of thing. You need a surgeon. So the answer is C. Now, what would be a situation? The 74-year-old male presents with a acute left-sided CVA and hypotension. Left-sided CVA and hypotension. The diagnosis is it's aortic dissection. The aortic dissection up the right carotid, causing a left-sided stroke. And a stroke with a low blood pressure, you're not going to see that very often, but there should be a buzz that this is aortic dissection until proven otherwise. Okay, that's it. You did 100 questions. This day is the end of it all. Tomorrow is much, much smaller.